Good morning, everyone. I know people will be joining us throughout, but for the sake of time, I want to make sure we stay true to our time. So I'm going to get us started. Welcome to the second day of MILI's Convene Conference. My name is Pinar Karaca-Mandic, and I'm a professor in the finance department and a health economist and the academic director of the Medical Industry Leadership Institute at University of Minnesota's Carlson School of Management. Thank you for joining our event. As our Dean Shriza here shared yesterday, for over 15 years, MILI has acted as a bridge between industry and academia, linking life science companies, entrepreneurs, policymakers, and business leaders as they bring medical innovations to market. This is the third year we are hosting Convene Conference. Convene's overarching focus is leveraging the intersection of healthcare and data analytics and how data and technology through business innovations can address big gaps in healthcare. And this year, when we asked our community which big gaps they wanted us to see discussed in Convene, there was overwhelming response in three areas: mental health, social determinants of health, and health equity, the three very interlinked areas. Our country, but especially we here at Minnesota, are at an uncomfortable whirlpool of events. Our hearts are broken for George Floyd and Dante Wright, and many others whose names we will remember. They are loved and their lives matter. We stand together today and forever, demanding racial justice in solidarity with our communities, especially with our communities of color. We know we are at a central turning point in our national conversation of racism, justice, and equity. Convene this year centered on health equity, and we cannot achieve this without addressing racism and justice. We're honored to have here researchers and industry leaders to advance this dialogue. Yesterday, our keynote and panelists highlighted gaps in mental health care, as well as key drivers and solutions. Today, we will be focusing on drivers of social determinants of health and health equity, and tomorrow we will continue this dialogue, focusing more on solutions. I remember being at a local conference in October 2019 and watching our Minnesota Governor Tim Walz highlighting the high life expectancy in Minnesota because we have high health insurance coverage and we're innovative people. In his words, quote, "Over the weekend, we get bored and innovate water skiing on a snowmobile." But he continued during that talk with strong statements on our achievement gaps, racial disparities that are, in his words, morally reprehensible and economically stupid. We apologize today that Dr. Marcelo Nunez-Smith, chair of the US COVID-19 Health Equity Task Force and senior advisor to the White House COVID-19 response team, could not join us due to a personal emergency, and she sends her regrets. But Dr. Nunez-Smith sent some remarks for me to read on her behalf, so I want to read the text she sent. Thank you so much for the invitation to be part of the Medical Industry Leadership Institute's Convene Conference. I am sorry I'm not able to join you, but grateful for the opportunity to share some brief thoughts in writing. I will start by contextualizing the health inequities we have witnessed in the case of COVID-19. Communities of color continue to experience drastically worse outcomes from COVID-19. Based on data from the first year of the pandemic, Black Americans were twice as likely as white Americans to die from COVID-19. Indigenous Americans were 2.2 times more likely, Latinx Americans 2.4 times more likely, and Pacific Islanders 2.6 times more likely to die. These numbers are shocking, and it is important to remember that these disparities are not aberrations. The COVID-19 pandemic has exacerbated a whole host of deep-seated social and structural problems that impact experiences of health and healthcare. People of color are far more likely to be uninsured in America. Of the 30 million Americans who are uninsured, approximately half are people of color. This lack of access to care has tangible consequences for the health of individuals and communities. 13.8% of Black Americans, 17.4% of Indigenous Americans, and 10% of Latinx Americans report having fair or poor health compared to 8.3% of white Americans. The systemic nature of these inequities calls for truly sweeping initiatives to lessen the disproportionate burdens these communities face in achieving health and economic well-being. I know the Medical Industry Leadership Institute is working to understand the landscape of our healthcare system through rigorous data collection and dissemination, as in the COVID-19 hospitalizations tracking project, which quantifies the burden on local hospital systems in all 50 states. As you know, our health system lacks cohesive and comprehensive data on health disparities. Our current data and data systems simply do not accommodate the socio-demographic complexity experienced across communities. While demographic data collection has improved since the beginning of the pandemic, the data is still inconsistent and incomplete, not only for communities of color, but for all medically underserved populations. We're taking much needed steps to establish viable data systems to understand disparities in the context of COVID. Data will be used to target resources to communities that need them the most, allowing vaccines, treatments, and testing sites to be deployed to those who would otherwise lack access. In the long term, this data infrastructure will be necessary to study and address the inequities that persist beyond COVID. As we continue to understand the ways in which COVID-19 has exacerbated existing health inequities, we also have to look toward the inequities that characterize healthcare institutions themselves. Collecting high-quality data will allow us to better measurement approaches and ultimately improve quality of care by identifying inequities in treatment and possibly linking disparities with high-impact consequences such as public reporting and payment penalties or rewards. But while collecting high-quality data is crucial to identifying health disparities, there still remain challenges to measuring healthcare discrimination. This is a space in which Medical Industry Leadership Institute is well positioned to innovate. Your experience with creating and evaluating needed technologies can be a great asset as we strive to integrate more comprehensive understandings of patient experiences. One of our projects at the Yale Equity Research and Innovation Center, the Patient-Reported Experiences of Discrimination in Care tool, or PREDICT, is developing and testing a standardized measurement approach for healthcare discrimination as a patient-reported experience. But there is much more work to do in our healthcare institutions to eliminate health and healthcare inequities. We must also call for healthcare organizations to develop a framework for anti-racist policies and practices. And we have to make a concerted effort to increase diversity in the provider workforce, in which specific racial and ethnic groups are grossly underrepresented. For example, African Americans make up 13% of the US population, but only 5% of the physician workforce. For African American physicians, our research shows that race permeates the experience of the healthcare workplace, from shaping interpersonal interactions to defining institutional climate. Strategies for addressing diversity challenges must continuously evolve and may require looking to models outside the medical professions. In conclusion, I want to leave you with these thoughts. We have seen the realities of persistent health disparities laid bare during this pandemic, and we need better data to begin to address social and structural determinants of health that cause certain communities and individuals, usually those of color, those underemployed, and with few opportunities for advancement, and those without health insurance, to bear a disproportionate burden of severe disease and death. Alongside these health disparities, we're also witnessing the results of long-standing healthcare inequities. Developing a framework for anti-racist healthcare systems and measuring patient experience of discrimination are necessary and urgent steps towards achieving health equity and justice. And this work requires us to also consider the professional environment in which those underrepresented in medicine work. Discrimination in healthcare settings affects both patients and professionals. We must persistently and entirely evolve strategies to dismantle roadblocks to equitable inclusion, look to innovative models outside our profession, and be ready to pivot on our approaches for justice, social justice. Thank you. Thank you, Dr. Nonia Smith, for these opening remarks, and we're sorry you're not able to join us today. Before we start the rest of the program, I would like to thank our sponsors for this event. Our presenting sponsor, United Health Foundation, our gold sponsors, Bind Health, University of Minnesota Office of Academic Clinical Affairs, Medtronic, and our maroon sponsors, Frederickson and Byron, Stella Care, Blue Cross Blue Shield of Minnesota, Mayo Clinic's Robert D. and Patricia E. Curran Center for the Science of Healthcare Delivery. I am now handing over to Dr. Tara Bishop, the Clinical Operations Leader of Bind Benefits, to introduce our Executive Spotlight Session speaker, Dr. Sachin Jain. Thank you, Tara.
Thank you, and thank you, Pinar, for the introduction. It is a distinct pleasure to introduce Dr. Sachin Jain to this webinar. Dr. Jain became President and CEO of Scan Group and Health Plan in July of 2020. And most recently, prior to joining Scan Group, Dr. Jain was President and Chief Executive Officer of CareMore Health and Aspire Health, innovative integrated healthcare delivery companies. He led growth, diversification, expansion, and innovation of these companies, and they grew to serve over 100,000 patients in 32 states with $1.6 billion in revenue. Under his leadership, CareMore built and scaled industry-leading programs to address loneliness, deliver hospital and primary care at home, and address the clinical needs of the highest risk, highest need patients. Dr. Jain was previously Chief Medical Information and Innovation Officer at Merck & Company. He also served as an attending physician at the Boston VA Medical Center and a member of faculties at Harvard Medical School and Harvard Business School from 2009 to 2011. Sachin worked in the Obama administration, where he was senior advisor to Don Berwick, when he was the lead of the Centers for Medicare and Medicaid Services. Sachin was the first deputy director for policy and programs at the Center for Medicare and Medicaid Innovation, also known as CMMI. Dr. Jain has published over 100 peer-reviewed articles in journals such as the New England Journal of Medicine, JAMA, and Health Affairs, and was an editor of the book, The Soul of a Doctor. Sachin is an adjunct professor of medicine at the Stanford University School of Medicine and a contributor to Forbes. In addition, he serves on the board of directors of Make-A-Wish of America. Sachin graduated magna cum laude from Harvard College with a BA in government and continued to earn his MD degree from Harvard Medical School and MBA from Harvard Business School. He trained in medicine at Brigham and Women's Hospital. It's a pleasure to introduce you, Sachin, and looking forward to your remarks today.
Thank you so much. It's really an honor to be here.
Thank you so much, Tara, and thank you so much, Sachin, for joining this conversation. So before I ask some questions to Sachin about his role and healthcare in general, I want to share with the audience, preparing for an executive spotlight for somebody like Sachin is so difficult because he has so many creative and thoughtful ideas. So it's kind of really hard to put it all together. And just in the last 10 days, I think, Sachin, I've seen your work written in Forbes, Health Affairs, American Journal of Managed Care, and all sorts of other places. So I want to start with the general idea that, Sachin, you've taken so many different roles in your career, including academic medicine, government, pharma, and now a payer, a Medicare Advantage plan as a CEO. And so reflecting on that journey, perhaps through the lens of your current role, what are some of the well-defined, and I know I've heard you use this term, fundamental deficits in our healthcare systems and healthcare system, and perhaps if you could elaborate on sort of pre-COVID and how they may have transformed or not transformed in the post-pandemic period.
Pinar, it's great to be here. Thanks so much for having me. And I've been looking forward to this conversation for a while. So really, really glad that we're finally here. I would say, my reflections on what is needed in US healthcare has really transformed over the last 10 years. If you asked me a decade ago what we really needed to get US healthcare on the right track, I would have said payment reform. I would have said delivery reform. I would have said we need more innovation. And I think we need all of those things. But I think the fundamental missing ingredient in us actually getting to the healthcare system that we want, and more importantly, the healthcare system that we need, is actually what I would say is more leadership. I think we need better leaders. We need more leadership. I think what we have in US healthcare is a lot of management and we have a lot of administration, but I'm not convinced that we have leadership. And what I mean by that is there's very few organizations and people in our industry who actually have a strong and sharp perspective on where things ought to go and are actually taking the strategic risks that they need to take to actually get themselves and their organizations there. We tend to really rely on consensus-driven decision-making. We try to go where everyone wants to go. We try to bring people along. Buy-in is kind of the currency of what it means to be a good leader, as opposed to perspective and driving towards that perspective. And so my diagnosis has changed, even though, I think, all the things I used to believe were important still stand. But I think how we're going to get there is going to be through more leadership, and it's going to be through, programs like yours and students in the program like yours who are going to actually create the kind of change that we need in U.S. healthcare.
No, and thank you for sharing. I mean, that's the kind of work that inspires us here all the time. And one thing that you said, the consensus-driven. One of my senior mentors, faculty member, late Dr. Robert Kane, one of his big things was consensus is not truth, and it's very, very strong statement. Sachin, I've seen you share thoughts on the fact that our business models are broken, and that you're a big advocate for this fundamental business innovations are needed. I believe the context where I've seen you make that statement was in the context of technology innovation, in that we don't have technology solutions to better manage, chronic conditions like diabetes, et cetera, because we don't have payment systems to do that. And that's ultimately that the business model innovation will have to drive the technology innovation. So it was in that context, but I've been thinking about it. Can we make the same argument for how our current business models are actually driving the health disparities that we see, and that what types of business model innovations are needed to address health equity and drive innovations to serve upstream and address some of these fundamental disparities that we see?
Yeah, there's a few different questions in there. I'll start with the business model. I'll start with the business model innovation question, then I'll go to the health equity question. So, I think, and they're obviously connected. I think health, business model innovation, I think is really important in that I think if you actually take a big step back and you look at what our problem is with kind of how we pay for healthcare in this country, is that we all make money when more money when people are sick. Hospitals make more money, physicians make more money, device companies make more money, durable medical equipment companies make more money, pharma companies make more money. And so the incentive isn't to necessarily do the things you need to do upstream to actually manage progression. And you see that in our reimbursements. We reimburse very heavily for complications of chronic disease, but we don't do a lot from a prevention and early management perspective of chronic disease. And so I think we have to kind of think differently about how we pay for care. And there's a lot of people who are thinking about that right now. On the health equity front, I think it is absolutely the case that I think payment reform will improve health equity, but it will require us to put it front and center. And what I mean by that is we have to build in measurements and transparency around performance that presently doesn't exist. If you were to ask the University of Minnesota Medical Center, how do we do taking care of Black patients versus white patients? At the end of the day, they will have a hard time telling you that because our data collection is poor. And we don't know oftentimes who's Black and who's white. And then we don't actually measure it. We don't talk about it. We don't track it. And so I think organizations need to do way more, within whatever payment paradigm, to actually measure their true performance, their true clinical performance. And I think COVID has been remarkable in that it has been one of the few times where we have very visibly tracked our public health and health system performance around, different populations by ethnicity, by race, and have acknowledged very publicly for the first time that we do better with some populations than we do with others. And, I think that's been very powerful. I think it's raised the visibility of the agenda. I think, Dr. Nunez-Smith's position, her remarks, were really a function of the fact that we recognized that there were these big inequities. Now take every single kind of major condition that we treat or manage in, society, and think about how we can create similar levels of transparency around performance in those particular areas. And I think then you'll start to see some progress. It's something that we're doing at SCAN. We recognize that we had lower medication adherence performance in African American and Latino patients than we do in Caucasian patients. And so we've actually put our money where our mouth is, and we're tying our 2021 bonuses to whether we can actually close that gap. And you bet people are focused on it, they're thinking about it, and they're taking the steps that are necessary to actually close that gap, because frankly, it's the right thing to do, but it's also how we're measuring our own personal performance for the year.
No, I was actually going to ask you about that because I have heard of that work. And so, yeah, I mean, the data collection is one thing to be able to put in the systems and collect the data. And I think what becomes sort of the critical is then, what do we do with those findings, right? How can we best use such findings? I mean, you mentioned in SCAN, you're proactively identifying this disparity in medication adherence rates. Can you say a little bit more about like how can we use these such findings? The SCAN is one example, but like what are some of the incentives maybe on the policy front that you would expect for more accountability to be able to use that data and make it more actionable?
So Pinar, I think the one thing I would just maybe underline and bold is the fact that very few organizations are actually talking about these data. And so, once we have the data collection, it's about actually making visible the fact that these disparities exist. I've been in and around the healthcare disparities field for 20 years, and we've done a great job from an academic perspective in documenting the presence of disparities. But I think from a management and administration perspective, you very rarely see organizations that are actually managing to metrics around disparities in performance. Which leads to the second part, which leads to your question, which is really this question of, from a policy perspective, what we can actually do. And I actually think we should be tying payment to health equity. So in the world I operate in, Medicare Advantage, we have this star rating system that actually, I think, very reasonably measures the quality of the patient experience and clinical performance of Medicare Advantage plans. And there are no real health equity measures that are embedded. And so I've been an advocate for embedding health equity measures to make sure that we aren't necessarily driving performance by serving only one type of patients, easy to serve Caucasian patients of higher socioeconomic status. If we're tying payments to performance, but we're not necessarily adjusting for who we're actually serving or looking for disparities that exist across different groups, I think we are maybe inadvertently widening disparities to the point of your previous question. I think sometimes the unintended consequences of policy is that we actually create disparities and amplify disparities.
Yeah, no, I do want to talk with you about the payment systems in a little bit too. I want to center our conversation to sort of really about this term, social determinants of health. So I read very recently, about a week ago, a thought-provoking piece by Tom Sullivan of Health Evolution. And the title of his piece is the concept of social determinants of health inhibiting progress towards equity. And in other words, in his piece, he was interviewing healthcare leaders, including yourself, and saying, I think his tone was about that there's this positive intent to the term itself, social determinants of health, but it is perhaps masking some of the most fundamental root causes. And maybe it has this tone of defeat or too difficult to solve or even excuse. And in a way that it is enabling our status quo that we know there are significant failures of the health system that result in health disparities. And so, you had a very strong statement there that really resonated with me. And I'm just going to quote from you. We have to call social determinants of health what it is, poverty and racism, and speak in plain English as opposed to creating these terms of art. Could you share more on this? What work do we have to do as the healthcare community?
Yeah, I mean, I'll share the context of some of my thinking on this topic, which is I was a couple of months ago sitting in a kind of a roundtable of health system leaders from around the country, and a health system leader from New York said, we're being held accountable for performance, but nobody's really acknowledging the social determinants of health and how they drive into performance. And I started to think about it and really hear it differently than I'd ever heard it before. which is I was hearing it as an excuse as opposed to an explanation. It's one thing to use, something to explain differences in performance. It's another thing to use social determinants of health to actually excuse your inability to actually reach people the way that you're supposed to reach them. And, and then over and over again in conversations subsequently, I would hear organizations, justifying lower levels of performance and justifying what I would describe as truly mediocre efforts to reach out to, low income and minority populations, through the lens of, oh, well, it's just the social determinants of health. And then you start to see what our industry is doing writ large, which is we're creating these kind of what I would call micro interventions, non-evidence-based micro interventions to treat the so-called social determinants of health that actually in practice really haven't been shown to improve anything. And I would say, to be a little bit blunt about it, it makes us feel better to say, oh, we're doing something to treat the social determinants of health. We're giving people meals after they get discharged from the hospital. We're giving them transportation to and from their appointments. Very, very important stuff. But at the end of the day, I think it's giving us a pass on the deeper structural reforms that need to take place in our society around poverty and racism, which is really what we're talking about. And so, what the term social determinants of health does is it creates distance between what we're really talking about, which I believe is poverty and racism. And it instead puts us in this kind of pseudoscientific realm of talking about, kind of non-evidence-based interventions to make us feel better about ourselves. I'm sure what I'm saying sounds a little bit harsh to some people in the listening audience, but when you've been in the rooms that I've been in, in kind of senior leadership roundtables around these topics, you realize how thin our true commitment is to actually addressing the real issues that we face. And I think healthcare leaders in particular, because of the ethical obligations that come from working in healthcare, have an obligation, not just to kind of operate their organizations, but to be advocates for their patients and advocates for their communities. And I would say writ large as an industry, we have a very poor history of actually serving as those kinds of advocates. And so I think we have an opportunity, as healthcare leaders, to begin to advocate for the right things for patients and communities. And sometimes it's going to be bigger structural reforms. Sometimes it will be, partnering with housing agencies. Sometimes it will be looking at tax policies and entitlement policies. But we can't continue to operate like we're in this kind of healthcare silo and everything needs to come through us, which is how I think a lot of people think about social determinants of health. If we are truly trying to improve community health and meet the obligations that we have to, our mission statements really that hang on the walls, then we have to do more than we're doing. And I've said we actually need a civil rights movement for healthcare. And what I mean by that is not just around kind of, racial issues and health equity. I actually mean we have to take lessons from the civil rights movement and try to pursue broader social activism, because I think future generations are going to look back at the healthcare system we had between, 1990 and 2020, and they're going to say in 2021, and they're going to be embarrassed that this society, kind of perpetuated a system with such grave inequities in the same way that we're today embarrassed by the racial discrimination that people faced, in the 1940s, 50s, and 60s.
No, that was going to be my follow-up question, because I have seen you post in your LinkedIn page that we need the civil rights-like movement to end systemic racism festering our healthcare system. And I wanted to ask a little bit, and you acknowledged that this would be a hard-fought battle. And so I wanted to maybe get a little bit more insights from you as to what that battle would look like. But before that, Sachin, I encourage the audience to send some of the questions that they may have, and I can try to blend them in our conversation. Actually, there is one question that does fit in to the battle. And so from your role, Sachin, what has been the most difficult thing you have had to or chosen to advocate for, and why? I don't know if you can combine them or
so I
think
I'll say, I've worked in an organization that has largely, I think, wanted to do the right things around, racial healthcare disparities and racial inequities, but I would say it was almost taboo to talk about them. because I think people didn't necessarily have a language with which to engage them. And I think one of the things that I'm most proud of is that we've increasingly started to talk about, our diversity, equity, inclusion agenda, not as kind of a freestanding agenda, but actually tying it to the excellence of our business. And I think the more you can actually tie being excellent at diversity, equity, inclusion to being excellent as a business, meaning, you have to grow in diverse communities. You have to make sure that you're serving those communities well. I think you're able to then kind of make it more of the mainstream issue in an organization. And I would say that's been kind of something I'm particularly proud of over the last year is, making it acceptable to talk about these things. My experience of healthcare leadership and leadership, more generally around racial issues is, the George Floyd event will happen. And then, a PR firm will be retained to write a carefully worded statement that talks about, the organization's commitment to diversity, equity, inclusion. And then it stops there. And there's no fundamental change in business process. There's no fundamental change in business strategy, no change in hiring practices, no change in vendor management. And people notice that. People notice when an organization is just kind of saying the right things versus doing the right things. And I would say one of the things I'm most proud of is I think we've aligned a leadership team at SCAN that is really about doing the right things as it relates to those issues, as opposed to just saying the right things. And I think, that's what the times call for, really, just given everything that we know and everything that we're learning about what needs to be done.
No, thank you for that. And as part of that, movement towards civil rights, like movement towards that, I want to bring our conversation back to the payment systems. And because you did mention, we need to pay for equity. And, so can we talk, and then you mentioned the star ratings as a very great opportunity to be able to do that. And what are your views on, payment models such as the value-based payment innovations? And do we have them figured out, or are there still some major barriers? And I know another thing I've seen you, I think, talk about was, again, SCAN's work around applying principles of value-based payments to pay for, I think it was in the case of homelessness. So if you could maybe elaborate more on some of those examples.
Yeah, I think we've gotten used to in our industry kind of thinking in terms of big policy changes as being a precondition to actually having the right things happen. And I would say what's changed over the last 10 years or 50, I would say 20 years, is we've had the creation of a variety of different ACO models, the Medicare Shared Savings Program, you have the Pioneer ACO program, you've now got the Direct Contracting Program, the GEO program. You've had Medicare Advantage become a dominant model of payment in several markets. And all of these approaches enable organizations who want to take risk to take risk. And, you can go so far as being fully delegated for risk, meaning you're 100% at risk for, the medical expenses for the patients that you care for, to, kind of a more modest form of risk, which is something that comes in the form of shared savings, or even upside only type programs. And so I actually think that if you are a leader interested in driving towards value-based care, you have all the policy instruments and all the payment instruments that you need, both from public sector payers as well as private sector payers, to actually get there. So the excuse is no longer, we need more policy reforms and we need more policy changes. That's why I increasingly go to this diagnosis of our fundamental pathology being leadership, because what you see time and time again is organizations that are more than comfortable staying, within a fee-for-service framework, as opposed to using the existing set of policy instruments to drive towards a payment model that actually rewards you for keeping people healthy and not necessarily taking care of you when you're sick. The leadership is missing to fundamentally re-engineer, the systems, how you pay people, and frankly, more importantly, even how you kind of bring your board along to actually align with these new ways of being paid. I once was talking to the board of a health system, and you realize is the boards of health systems are populated by titans of local industry, and in those all of those companies operate in fee for service. or your revenues only grow when you produce more of your goods sold. And in healthcare, what we want to do is we want to move to a model where you're actually selling fewer goods, but actually keeping people healthy. And that's not intuitive for people to really understand in the context of their other businesses. So I think, again, the governance of a lot of healthcare organizations is dominated from people who come from other industries that are, fundamentally fee for service. And so I think that is one of the challenges that we have, is actually, kind of educating the leadership of these organizations, not just the senior management teams, but also their governance, their boards, around kind of why this era of healthcare needs to be meaningfully different than past eras.
Yeah. And of course, something we talked about, something that has to complement, is the data systems needed for that we need to set up for this equitable value-based care, and the outcome measurement, and which are, as you mentioned, and as Dr. Nunez-Smith mentioned, are largely lacking, that really need to be advanced. There's a question from the audience that kind of furthers this conversation. Having worked in both the private and public sectors, how do you envision public-private partnerships being leveraged to best promote health equity?
Yeah, I think that there actually needs to be a lot of harmonization around our efforts. And I think one of the things I worked on aggressively when I was in government was actually, how do you harmonize payment policies, administrative policies between payers, the public and private sectors. When I was at CMS and ONC, I realized that there were 20 different pay for performance programs in any given market that actually measured different things and created a high degree of administrative complexity that ultimately made it challenging for organizations and physicians, doctors, provider organizations to actually participate in these types of programs. And so again, I think there needs to be more harmonization. I think there are obviously concerns around antitrust and antitrust enforcement. And so again, I think that's an area where we need to continue to have some policy innovation. But I do think kind of the private sector often follows the lead of the public sector in terms of developing measures and developing programs. And I think we just need to see more and more of that across sectors.
Well, thank you for that. Another area I want to get your thoughts on is, we're talking about change, and some of the things you said are really about fundamental change, right? And I agree with you. We need that. We need that kind of change. We need that kind of leadership to push for that kind of change. But we also know some of the characteristics of our healthcare industry in general. I want to prompt you about the speed of our industry, right? So telehealth, for example, it took us decades until the pandemic. And then, so can you comment on some of the fundamental structural problems that inhibit speed in our industry, in speed of action, perhaps?
Yeah, I mean, I think we've convinced ourselves that change in healthcare needs to be slow, incremental, plotting, consensus-based, buy-in oriented. And, I think, what we saw was that it was taking, 20, 30 years since, the creation of the appropriate technologies for telehealth to become a dominant model of care. Then enter COVID, right? And, what we saw is within weeks, organizations that said that they could not embrace telehealth, that it was too organizationally complex and challenging, they were up and running because their survival is dependent on it, right? And so I actually think that we have an opportunity to continue the pace of change that was adopted during COVID, when organizations got less concerned with, kind of managing their internal dynamics and more concerned with, fielding what works for the people that they serve. And, so again, I think we need to not waste this moment to adopt the organizational culture that was necessitated by the pandemic, but that ultimately is going to be the accelerant to the type of change that we need to implement to make things really work for people in the post-pandemic era. I will say, I'm realistic though, which is that I think, organizations are organizations, people are people. We're probably going to slide back into some version of, where we were before, which is slow, plotting, deliberate, consensus-based. But I would challenge those of you who are working in this space, or will work in this space in the future, to think differently about this topic, because and to challenge your organizations around pace. I frequently talk about the experience of being a medical student trying to introduce some minor innovations to how we rounded in hospitals, and going through committee after committee after committee after committee, only to finally just get exhausted. And I know that there's many of you in the audience who have had that experience. I know that because when I talk about it, I will always hear someone say, "Oh, that happened to me too," around this idea I had. And I would say, I always committed to myself that when I was in a position to kind of authorize change in an organization, that I would make it simpler for people, and I would say yes when I wanted to say yes, and I would say no when I wanted to say no, and not send people on these kind of wild goose chases of kind of passive aggressive consensus building. And I've largely stayed true to that. And I think many of you will be in these types of positions, or are in these types of positions, and would encourage you to reflect on your own behaviors and the extent to which you make things either complicated or simple for people. And the simpler you can make them, the happier everyone is.
I think I've seen you use the term death by pilot, and it's true. Yeah, absolutely. So looking into the future, because you did have some future remarks for people in the audience, and we have entrepreneurs in the audience. And so what type of innovations from startups do you think we will see, or that you would like to see, towards the path to improve health equity and drive down disparities?
So I think that there's, I would actually say the healthcare startup ecosystem has largely not adopted the agenda around health equity. I mean, I will say, I have seen, literally thousands of startup pitches over the last, decade, from my time at Merck to my time at CareMore to now my time at Scan. And health equity has not been kind of a primetime topic for the healthcare startup ecosystem. I would, to your point, Pinar, I think it's an amazing time for, for entrepreneurs and startups to actually adopt that as a focus, because organizations like ours are looking for solutions in the health equity space and, want to do a better job. And, I think there's a lot of organizations like ours that are in the same place. And so I actually see health equity as being a really terrific opportunity for, the current generation of entrepreneurs, kind of pivoting with their current set of solutions to do more in the health equity and disparity space.
Oh, thank you. And thinking more on that innovation in healthcare space, what are your thoughts on innovation within the healthcare system versus outside?
Yeah, I mean, it's a really interesting topic, and I think Haven learned a really important lesson, or taught us an important lesson that we keep having to learn, I think, as an industry every 10 or 15 years, which is it's very hard to disrupt a system when you have a high degree of interdependence on incumbents. You might be able to build a new primary care model, but you're not going to be able to stand up a new hospital, a new PBM, a new dialysis model. And so even if you're trying to enact wholesale change in the system, the value chain, because of how complex the delivery of healthcare is, really requires, continuing to partner with a set of incumbents. And you can't simultaneously disrupt incumbents while also rely on incumbents. And I think that that's one of the kind of challenging lessons that I think people learn over and over again in this industry. And so, when you think about the model of change can't be, I'm going to stand on the side and build something totally separate. The model of change has to either be, I'm going to change the platform on which everything works, which is, maybe payment reform is an example of how you could change the platform around which everything works. Or you have to take your one piece of something and then still find a way to interconnect with the rest of the system. The big, bold statements around, oh, we're going to transform healthcare are really great for your PowerPoint deck. But at the end of the day, you have to kind of recognize the complexity of the task. And I always judge healthcare entrepreneurs by the extent to which they actually truly understand the complexity of the task. Healthcare is one of these fields that consistently welcomes kind of new entrants who believe that they, if only they did it, the way that their field did it. And it's a very humbling field over time, just because there is a set of, organizational dynamics, industry physics that I think end up being different from what people expect them to be when they're looking at it from the outside.
I like that term, industry's physics. Is that?
Yeah.
So to end with one difficult question, maybe not that difficult, but as an economist myself, it's sort of an obligatory that I ask a trade-off question, right? So access, affordability, and equity, these are all related, but there are trade-offs. So ideally, we want to identify some policy recommendations that is going to advance all three in some balanced way. In your opinion, are there examples of such policy recommendations in our sort of really fragmented system? Or is there no way to make everyone better off without some getting worse off in some disproportionate ways?
I love trade-off questions, and what you really get to is, I think, is American healthcare's fundamental unwillingness to accept trade-offs, right? We think everything can get better without some parts of healthcare not getting better, not being worse off. And I think, in a multi-sectoral industry like healthcare, you have to pick sectors where you believe you can take from, and then you also have to think about the sectors that you want to give to. And what I will tell you is, writ large, I believe that we should be strengthening the primary care infrastructure. We should have a healthcare system that provides 24/7 primary care, access in outpatient settings, continuous contact with a group of people who know you and care about you. And we should do everything we possibly can to keep patients out of the hospital, because hospital care, with the exception of kind of elective procedures, is really a failure mode. It's a failure of something we didn't manage effectively in the outpatient setting. So I believe that over time, what the sector we need to shrink is the hospital sector, the acute and post-acute care sector. And this part that we have to improve and invest in is actually our outpatient primary care sector. And I'll just put a plug in for a paper we had in Health Affairs yesterday, me and my former CareMore colleague, Balu Gade, around the notion of the confident generalist. We need to center more and more care around confident generalists, physicians who manage and own most of the experience of the patient, as opposed to, kind of continuing to triple down on the system that we have right now, which is, people are lost in an uncoordinated web of care that, ultimately no one's, owning the whole outcome for the patient. And so, that, to me, the notion of the confident generalist, it is the center of the answer for what we need to do going forward.
Thank you so much, Sachin, for your time. It's been wonderful to talk with you about all these lots of different questions, but they're all linked together. And I think what I'm going to take out of that is that we need that civil rights-like movement to make change, and that we really need to think about the language we're using in defining social determinants of health. And just like, as you said, just use plain English and really get to the root causes and address those. So, and thank you so much. And thank you for serving as, as a CEO of a pair and taking a lot of accountable measures. So to our audience, we will
Thanks so much, Pinar. Appreciate it.
Thank you, Sachin. Thank you.